So, hello and welcome to Fairwinds Medical Healthcare Unscripted Podcast. I'm your host, Dr. Chris Leslie, orthopedic surgeon. I currently practice in both Texas and Mississippi, and we are honored and grateful to have as our guest today Dr. Mark Schultzel. He's an orthopedic surgeon. Welcome, Dr. Schultzel. Thank you for being here.
Thanks so much for having me.
I know that we spoke the other day, and some of the areas of certainly interest and expertise that you have has to do with, let's start with injections. Obviously, this is something you've spent a great deal of time on, perfecting your technique, learning new techniques, as well as the administration of the medicines that you do. So tell me a little bit about how you got interested in that and what part of your practice, what scope of part of your practice is that?
Yeah, it's a really great question. So I work with a lot of trainees. So I have medical students, residents, and fellows that run through my practice. And my practice is more like private emic. So I'm a private practice, but I take on a lot of trainees. And really what I wanted to do was develop systems where the trainees are becoming more accurate with their injections. I see a lot of patients come to my practice that have said, I got a steroid injection from my primary care doctor. It didn't work at all. Can you do better, or what's going on? And then when I look and see the trajectory or the technique, it's not a standard technique that's really going to use the anatomy and do what we need it to do. For the shoulders, the biggest issue that I see is folks will inject from posteriorly. And I think there's a really high rate in this because we have to remember that the glenohumeral joint is not just like a straight line. It's rotated. So there's curvature inwards in that concavity of the glenoid, and you can't feel really well the back of the shoulder. And patients are not going to let you dig around in the back of their shoulder with a needle. And so one of the ways that I describe it for my students is if you look about the thickness of the needle cap, that's about the thickness of the trocar when we do arthroscopy. And it can sometimes be really challenging to poke through the posterior capsule and get into a joint posteriorly. I use it to be like, then why are we really injecting from the back? So the way that I train in my fellowship, I had an amazing mentor, Dr. John Itamura, out at the Curl and Jobe Clinic in LA, and he actually taught me to inject through the front. So we go, directly anteriorly, just go right off the coracoid, and then I use ultrasound to also help improve my accuracy. And so that way you can get into the glenohumeral joint very easily. You can get into the subacromial space at the same time with one needle stick, and then you can even tilt upwards and get in towards the AC joint. So just through one needle stick, now you've addressed three potential problems with pretty good accuracy. It's repeatable too. And when you do your arthroscopy, you do your anterior needle placement through direct visualization. And it's so easy to get that in there. So it kind of reminded me like, hey, we should be doing these kind of standard procedures, and then we got to teach them that way. A lot of our students are not going into orthopedics as much as we'd love them to. And so then if they go into primary care or internal medicine, they can still do these injections with pretty good confidence that they're going to help their patients.
I could not agree more. I absolutely agree with that. So I go in anteriorly, and I have the arm up at 90 degrees, and I come in, and then I internally rotate the arm so that it just carries the needle into the joint. It's a lot more comfortable for the patients, and then I agree with you. You can access all three areas that you're trying to inject by doing that. And also, I think my patients find it less uncomfortable, if that's a phrase, than going in posteriorly. And also, you're spot on with the fact that I just think the accuracy from going in posteriorly, as well as the ability to hit all three areas that you're trying to get, is pretty compromised. So I've never really had a patient complain about it. I mean, I have my patients laying down. It's so much easier. And I'm sure as you found in your practice afterwards, many of them go, that's it. And so that part's nice as well. Yeah, and I never understood really the posterior technique. And I agree, the angle that you're trying to hit there is very, very difficult. So I know that you also have a very strong interest in training and students and fellows and residents. So how is that a part of your practice? And I assume where you are with such a busy practice that you're just inundated with people wanting to be on your rotation.
Yeah, it's been a huge part of my practice, and also I have a twin brother who's a general and colorectal surgeon, and he's integrated into his practice as well. We're so proud of it. Where I train, I went through college at UC San Diego, medical school there, and then a residency in Kansas City and fellowship out in LA at Curl and Job. And I really didn't find I had one mentor in residency who was a shoulder surgeon, and thank God I found my shoulder elbow fellowship mentor, Dr. Itamura, who's become like a second father to me. But I didn't really have any other mentors or teachers or anybody really helping me along. And my brother had the same experience. There was nobody really who was in our corner and that much of a support. And as how competitive it is in medicine, and sometimes how lonely it can be, we really thought it was important to pay it forward, and try to change the culture. And I think, especially in competitive markets like here in San Diego, where we both practice, in medicine, we have a tendency to eat our young. We're in
True.
training. You can remember the really mean attendings that were, trying to like toughen you up or whatever they were trying to do. But I just don't think it has any of those positive effects. And I think it actually inhibits your ability to truly learn and grow. And then we have these medical students that may consider surgery or may be afraid of surgery because they're like, oh, in surgery, there's a reputation, and oftentimes it's a negative one. And so we wanted to flip that upside down. We actually, some of my most proudest moments are when the medical students come back, sometimes they come back for a fourth year rotation as an elective. And I think the biggest compliment to me is if I get one comes back who's going into psychiatry or family medicine. They're never going to do surgery again, but they had so much fun on their rotation and learned so much that they wanted to actually do it again, which means that we've now positively changed the culture to make it. And I mean, it's not like you're just making it fun. You're making it meaningful for the trainees so that they get something out of it, and they've taken stuff from it that they can apply to their patient care. So even if it's a medical student going into psychiatry, they're going to have patients that they're taking care of that are going through surgeries or have gone through surgeries. They can appropriately counsel the patients about what they're going to expect and experience, whereas maybe
Yeah,
they wouldn't have had they not had a good experience.
I totally agree with that as well. Yeah, you're right, and I think a lot of medical students and even people in a general practice residency program, they are afraid of surgery. I found it amusing when you said that that sometimes they get an orthopod in training and it's just a miserable experience. I often thought when I was training that some of that was to um, chase potential competition away. Like, don't come practice here, go someplace else. And so I think that unfortunately, then that it does affect the culture and the perception of our specialty. And it takes people like you who are really taking the time with these students and interns and residents because you're also right. Yeah, they're never going to be a surgeon, but when they then go back and counsel their patient, that patient comes to you more educated and not as afraid. And that's really important because I'm sure you see it. I see it all the time where they basically just say, go see this orthopod, and that's all the explanation they get. And so if they actually come in somewhat prepared, that makes for a more pleasant experience for everyone. Plus, you can usually accomplish what needs to be done. So I commend you for that. I think that that's a culture that has to be changed, and it will take people like you and mentoring. Um, and again, when those people leave your service, they have a positive experience, and they will carry with them throughout their career. I think that's terribly important. Um, so you do a fair amount of teaching. Tell me about your practice a little bit.
Yeah, so large private practice. We're part of a multi-specialty group. So we're 40 medical and surgical specialties, and we're 150 doctors. We're all private practice, and we cover most of Southern California. So we have various services in various counties. I run our orthopedic department, and then I actually got into it because my twin brother runs our general surgery department, and they wanted to build a surgery group for orthopedics. But it's really cool having providers and docs from multiple different specialties. So if I have someone who comes in with cervical radiculopathy, I can refer them to our pain doc. If they need surgery, we can get them to our neurosurgeon surgeon, and it can kind of all stay in-house, but it's all private practice. So the onus is on us to be hardworking and to create a great practice environment for our staff and our patients, and that's what keeps patients coming through the door. And we have doctors that if they're not working hard and don't have a good reputation, they don't last really long in the practice, because we do have a standard of, we want our doctors to be the best, do great work, are really nice, take good care of patients, and that's kind of the ethos of our practice at United. Involving the medical students and the pre meds and the pre PA students and the PA students has been a great boon, because it's one, having all the young people in is great because they're super excited about medicine, and then it creates like a great network effect. So I have, my staff are all pre meds from UC San Diego that have finished and graduated but are doing their gap years, and so they desperately want to be in medicine, so they work so hard and have really increased the positive culture that my patients experience. And then they help the medical students get integrated to the rotation. The medical students turn around and help my staff when it's time for them to apply to medical and PA school. And so now you've created this network of friends and colleagues and allies. And then, some of my very first students are now practicing here in San Diego in various specialties. So now I have people that I thought were great that I can refer to them, and they refer back to me. So this is how you've created this positive network of pals and colleagues that do good work, and that have kind of united under the same ethos. And it's also, you kind of freeze out the competition who are not behaving well, the docs that don't play nicely in the sandbox, or who aren't doing a great job, and don't treat each other well. You can vote with your feet, and hey, we all will refer to each other and take care of each other, because we all care about patients and have the same mindset. And that's how you kind of like force change from the ground up. And so we've been really proud about that process.
And you should be. I mean, especially from the concept of you're approaching it from trying to change the culture standpoint. It also speaks very well of you and your group. It's hard to keep 40 private practitioners together. That's remarkable. I mean, you've seen 2 and 3 man groups that just can't handle it, and so they go their separate ways. But to have 40 of you underneath 1 or 2 roofs and be able to keep that large group together is remarkable. I don't know that I know of another one that is that big and doing that, especially private practice. But also, I think your point of um, keeping people who have the same ethos and culture that you guys want to project from your practice is critically important. And you don't have to put up with the bad actors. They can go someplace else. So I think that's terrific, and I congratulate you and your partners for being able to do that and continue to maintain it. Um, Tell me a little bit about from the standpoint of as you bring new partners in and other partners retire, how do you handle that transition? Because I'm sure you have both all the time.
Yeah, so we have our CEO is amazing. He's actually a physician, so it's a physician-run practice. And so Dr. Hong, he was a gastroenterologist by trade, and I think having a physician be the lead of this, he also understands, because he's also a very high volume physician himself. So he gets the hardworking ethos and has created that culture where, as physicians, we can come to each other with problems and issues. And in our group, I think there's a general set of like when you're ready to transition in and out of practice, and like we don't have a schematic setup where the senior partners can do, which is very common in many practices, is kind of skim off the junior partners. You are purely production based. And then we have our ancillaries and stuff, but we reject the traditional schema, and I see this in a lot of orthopedic surgery departments across the U.S. These private practices where the senior partners are just not willing to give up the ghost. They don't want to stop in the practice, but they're not actually doing any volume. But then they're skimming off the young guys, and then the young guys and gals they're doing all the work, but they're not really getting paid. And I see this time and time again, and it's really what it is. It's a pyramid scheme. We just don't call it that because we doctors, none of us went to business school. But I remember when I was sitting in my corporations class in my MBA program, and all of a sudden the light bulb went on, and I was like, oh my gosh, this is what is going on. Like what pyramid schemes are is what's happening in a lot of these practices. But we have really embraced the idea of fairness. Like if you work hard, you will be rewarded. If you don't work hard, you can't run off anybody else's coattails. And I think that's one of the ways that we keep people in the practice well. And it allows people to phase out when they're ready to kind of sunset their practices. And so, I mean, but it's a tough nut to crack because it takes one of those cultural changes.
Yeah, I agree, and I can tell you from personal experience when I first came out into practice, I joined a small group, and I was fresh out of residency, very ambitious, really wanting to work hard, and I found out after about a year there that I was doing almost 55% of the work, but we were all being paid the exact same. And it's like, well, wait a minute, that's not what I signed up for. And it's you want everybody pulling in the same direction and trying to be as competitive and productive as they can, because I believe in being paid for production, as long as you're putting out good work and you've got a big enough group that you're able to self-police the quality of the work that's coming out from your partners. So this is a multidisciplinary group, not just orthopedics.
Correct. Yeah, we're 40 medical and surgical specialties, and we have over 150 doctors and PAs. So we're
Wow.
big. Yeah, and it's great. And so we're the largest private practice in Southern California. And again, it's Dr. Hong has an amazing vision, and then we all as his partners, we all carry that torch. And essentially, it's nice for me because I run my practice, as does my brother and our other partners. You can run it. It's like Burger King. You can have it your way, and as long as you're running your practice well and are putting out good work, everything's hunky dory within the practice. You can also, if you want, have our United, like the central practice, run your practice for you too. But for me, I really wanted to be hands-on, just with the nuances, what I do with the teaching, and a lot of the innovation work and the tech work. And so I thought it was a better way to do it myself. And I've really enjoyed it. It's been one of the most fulfilling things to be able to grow your own brand, and expand it.
Yeah, I agree with you. And so you're actually able to be in the same practice with your twin brother? That's really cool.
Yeah, kind of odd to have bones and butts together, but this is the way we make it work. So, but it's great, and we operate at the same hospital too, so it's super fun. Sometimes we're in rooms adjoining to each other. Our staffs both really like working with each other, so it's fun to see your best friend at the hospital, and he's an incredible surgeon. He's the busiest robotic surgeon in the United States, and his skill level is, I would say probably the best in the U.S. for what he does. And so I'm his biggest cheerleader, but I'm beyond proud of him. So I often say, I hope I'm even half as good of a surgeon as he is, and that I'd be doing pretty okay.
I'm I have no doubt that you are. I think that's terrific. So I'm also just gathering from listening to you talk about how you treat well, you and your partners and the practice and everything, but I'm assuming as well as when you talk about the culture, I'm assuming that you over time have been able to train up and keep the good techs and the good assistants that you have, because that's, as you know, and as I do, your your techs can make or break you. So I assume that you have been able to do that over the years, and especially with a group that large, and keep your good people by your side. They know what you're going to do. They know what you need before you ask for it. Sure, certainly makes your life easier.
Yeah, 100%. I think a lot of people forget about the value of a good, consistent team. And so we've really been able to grow that. We're really lucky at the Sharp Hospital where I do most of my operations. I've got essentially three teams of scrub techs and OR nurses and circulators. At any permutation of those three teams, we get great results. And so I feel very, very lucky because if I walk into an OR day, I know they know exactly what I need. And that consistency saves you time, saves you, anesthesia that the patient has to be under because your case is shorter, makes things more efficient. Or if you need help with something, they know what you do. Everything to the sterility with the proper draping. So many things that are positively affecting the patient care. And so I think it's hard, back right after COVID, we had all these travelers and we had a big loss of our nursing and staff shortage. And so I think it made it really difficult. You would have a staff member du jour, but now that we're back up to a little bit better numbers, having those consistent partners really make it a great thing. And then these are people I love working with, and I hope that they feel the same way. We have fun in the OR. We tell stories, we make jokes, we play fun music, we get along well. So it doesn't feel as much like work because you're working with all your pals. You're working with your friends, fixing problems, and then maybe going out for a beer afterwards. So it's a great way to work every day for me.
Oh, 100%. I could not agree with you more. And the fact that you are able to keep your staff, it also improves your outcomes because, like you were just saying, they know what you need, when you need it, how you need it, and what the goal is. Because you know as well as I do, there are times when only two people, maybe three, if you include the rep, know what the point of the surgery and what the expected outcome is. And when you've got somebody who's there by your side and they've helped you do it 500 times, it, as you just said, it makes your a day a whole lot more pleasant. And again, you get better outcomes when you've got people around you like that type of team.
Yeah.
So I think that's terrific that you've got that. And also, from a teaching standpoint, it's important for the med students and the PAs and the interns and residents to see that uh, type of treatment because also, as you've seen and I've seen, there are guys that don't do that, and so people just don't want to work with them, and I think that negatively affects their outcomes because they're just looking for a way to get out of the room. But I do the same thing that you do. I come in, we turn on some music. We First thing I ask every morning is, "How was your weekend? What'd you do?" Because as you also know, human nature is people like to talk about themselves, and so when you create that environment where I'm interested in what you're doing and what your life is, tell me about it. They do better work for you.
Yeah, absolutely. I think it's all the culture you set in the operating room. I think even also from a safety sake, I've always been, hey, my OR is an open book, open communication room. If you see something, say something. If I'm about to do something dumb, please tell me, type thing. Or if I'm struggling and you think there's something I can do to improve this case, say something. Because especially as you're starting as a surgeon, you got to be open to that because some of the techs and nurses have been doing this for way longer than we have, and they have an incredible amount of perspective. And so then you're leveraging that for the benefit of your patient care. And so I love that too because it also makes my staff. Hey, if there's like, let's say I'm about to get in the room and now all the carts are contaminated, and my staff are now not afraid to come talk to me about it. They're like, hey, we're like, hey, like the tray's contaminated, but we did this to try to fix it. So when your staff and you have a really great relationship, they're going to be more proactive about solving problems instead of passive. Like if they don't like working with you, they'll be like, oh, hey, sorry, doc, all the trays are contaminated. We got to cancel the case. Womp womp. Too bad, so sad. But my staff are like, hey, we identified that this is a problem, and we did this, this, and this, and this is what the plan is now. Are you cool with that? And so I'm always like, yes, that's great. Thank you for doing that. They just solved my problem for me. But I don't think we would have gotten to that point if we didn't have such a good relationship.
Oh, I agree. And I don't know if you had this experience, but I remember when I first came out in practice, maybe I'd done, 25 hip nailings, basically on my own as the lead surgeon as a resident. And then I came out into practice and I realized, well, this scrub's done 500 of these. You know, they know what's supposed to happen and they also know whether they're doing a good job or not. So I think that is a humbling experience, but it's an important one to learn that these people can really help you and affect your outcomes. You know, God bless them and treat them all with respect and kindness. And I agree.
Yeah.
So tell me a little about your robotics. You and your brother, and are you doing robotic knees?
Yeah, no, I'm mostly shoulder elbow. A couple of my partners do robotic knees. I'm toying with it for the shoulder, so I've been doing some stuff with the robotic, a little research on it for the shoulder, and then I use the Apple Vision Pro, which is a 3D goggles, and I use that for a lot of my arthroscopy cases. My brother does a lot of work with the Da Vinci robot, so he was one of the first guys to use that new Da Vinci 5 in cases in the world now, and then he kind of pioneers the single port surgery for the colon. I think with the shoulder and the hip and the knee, and initially it just was kind of like a marketing gimmicking tactic. And I think the research just shows that patients don't do necessarily any better. One of the companies that I think is pretty good in terms of improving patient outcomes that I've seen, it was one of my partners uses a robot company called Omni.
Hmm.
that they're very good in that they really minimize your gap balancing error very, very specifically. And my partner, none of his knees are unstable. Like, I've never seen him have a gap balancing issue in all the years he's been using it. So I think that's been kind of a win. With the shoulder, I think it's hard because that joint is so dynamic, and dealing with like glenoid surfaces, I think can be challenging because of not only retroversion, but the newer thing that's a hot topic is superior inclination. And so I've been toying with it to try to find ways of making it work. But my other problem is that, I use very cosmetically based incisions. I'm in Southern California. I have an efficient way of doing the cases, and I'm getting great results using kind of the company and the technique that I'm using. So I've actually kind of leaning a little bit more towards using Apple Vision Pro to put a CT overlay directly over my glenoid. That way, I don't even need a cut guide, and I know exactly where to put my pin with much more accuracy. Because for shoulder placements, the where you put your glenoid or your glenosphere, that essentially makes or breaks your case. And so that is probably the single most important part of the operation, and that's where the most error occurs. And so I think that for me is going to be the biggest win and thing that's going to make the tech advance better.
I would agree with that as well. So it sounds like you have obviously a high volume practice, but it sounds like you also do a lot of teaching and training as they come through your program. Where do they come from to be on your rotation? I mean, are there a couple of schools that feed them? I know you referenced Kansas City as part of your training. I'd like to touch on that because I'm a Missouri boy back in the day.
Yeah.
But how do you, the quality of training that you're seeing coming through your program? I've seen it, and I know you've seen it. Sometimes you get somebody who's just directly out of school and they're terrific. They've got good hands and they learn quickly. Then you'll have a fourth year and you're like, nope, this isn't going to work. So you have to see the whole spectrum. How do you handle that in your practice when you have people come on your service and you have to quickly assess whether they have the skill set to help you or not? And then also, that's question one. And then question two is, do you have any mechanism for helping to train them up? Because I mean, you're obviously a busy practice. You can't handhold everybody, while you're trying to teach them. So those would be two interesting perspectives, I think, of your very busy practice.
Yeah, absolutely. Great question. So, I take on medical students from my local medical school where I went, my alma mater, UCSD, and then I take on med students from a number of the DO programs. And I thought that was really important because none of them have a home program or home orthopedic program. So how else do you get involved in these type of rotations? So I take from the two Turo schools, and then every once in a while, like I get a number of students coming from international or from other programs across the country that want to come and spend time. And I do some mentorship through the AAOS Launchpad. So through the AOS Launchpad and the Shoulder Elbow Society's mentorship group, I get residents, fellows, and young attendings that also come and hang out with me and spend time. And then I'll take on every once in a while some of the residents from our local area. I think the biggest thing that I see is that in the programs that are considered like white collar, meaning, like they have the big famous names, I feel like they're not getting as much operation time and experience as you would expect. And it really is affecting me when I try to counsel my students about like where they should go for residency. I really am encouraging them to use like what we call like the blue collar programs. I went to one of those in Kansas City, and it was a great operative experience. We were in the trenches doing a lot of operations, and I felt like that's really where I found my hands. So then when I got to fellowship, my hands were okay, and my mentor was an incredible teacher and really maximized my potential. But a lot of people are at these programs where there's lots of fellows already, or there are high profile surgeons that don't let the residents operator get their hands wet because of what the institution is. And so I think it's doing a disservice to the trainee, because at the end of the day, your diploma behind me on the wall is not going to save me from a problem in the operating room. However, your experience, you have to get good hands. And so you need to go to a place where you're going to be competent in your skills afterwards and able to do, standard of care surgery. But if you were never given the chance, you can't be expected to be, come out of training and just know everything perfectly. But I see it more and more, and unfortunately, it's especially at those programs that are just very famous.
True. And yeah, again, I think you're spot on with that. We talked a little bit the other day about um, DOs and MDs, and one of the things that I've noticed is that The DOs typically get to start doing surgery earlier in their training, and so when they come out, they got a fair amount of experience, and I think that that makes a big difference not only in the trajectory of their career, because as you and I, as attending orthopedic surgeons, we would welcome that and encourage that and um, uh, ex extend that person's possibilities and opportunities because we want them to continue to grow. As opposed to, not that I have anything against the fourth year guy, but if he or she has never done any real surgery, um, I can only spare so much time to help and try to train them up. Um, so, I think that this programs where they get to come out having done a fair amount of surgery, obviously under somebody's tutelage, but they have, as you just said, they are finding their hands if they haven't already found them. And it makes not only a more pleasant experience for you and I as they're attending, but also I think for their patients and the outcomes that they get.
Yeah,
Um,
no, 100%. I think, to answer your second question, for the like, how do you maximize that time? I think it's really like one resource that people forget to tap is like leveraging the medical device companies for courses. So as many courses and cadaver labs and sawbones as you can get under your belt. You need to get all the reps of practice as you can. That way, when you get into the real game, you at least have some notion of what to do, or your hands are a little bit more comfortable with how to hold things or where to position, how to do a reduction. But it only works with practice. You can't read it in Campbell's and just assume that you're going to get it, or like, yeah, the AO website does like step one, do this, step two, do this. But in actuality, it's really hard. I always, one of my medical school professors, she's a trauma surgeon, and she was a magician at getting reductions. And so I'd be reading in the AO manual, like, it says step three, get the reduction, but it doesn't tell you how. And she could just almost like magically to me put it back together. But she had learned special techniques in her residency and in her, she had an incredible fellowship training up at Harborview. Um, and so I was always enamored with her ability to do that. And I would very often think in residency, like, how did she do that again? As I was trying to get these
huh.
reductions. And every time I would do a case, like I would just think back to her and be like, wow, she's incredible. And then finally, when I did learn some of these techniques, actually, I even respect her even more because she could do it with such finesse and ease. It was like she instantly knew what to do. But these are things that I don't think she would have gotten either had she not been given all these opportunities to practice them. And, even she was very encouraging to be telling, the medical students, yeah, when you're in residency, go do labs, go do as many courses as you can where you can get hands-on training, because it's that extra time spent outside of the OR that I think pays dividends later.
That's terrific to have a mentor like that because, as you just said, it not only makes your training better, but also they improve the entire field. And if they have that positive environment where people want to come on their service and they know that they're going to learn something and they're going to walk out of there better equipped to go on, even if they don't go into orthopedics, but whatever area of medicine. I think it's really, really important, and I'm so happy that you had a mentor like that. I did too. Um, I remember the first day of my residency. Um, I sat down at a table with this guy, and he had that gift of letting you do the surgery but get the outcome that he wanted, and that's rare. I think it's really important if you have a mentor like that. Sounds like you did. Um, and even something as simple as a reduction, sometimes they're not all that simple. Sometimes it just doesn't come together. And so, if you've had that experience where somebody has been able to show you different techniques and tips and tricks to get those things done, I think that's terrific. I'm glad you had that experience as well. And it sounds like you're extending that to the people that you're teaching as well. And they will remember you for that. Let's turn the page a little bit here, but while we're kind of winding down here to the business of medicine, as I mentioned earlier, to have 40 people in private practice is really unusual, especially since the trend is going more and more towards being an hospital employed physician. So Is this just a philosophy that your group has always had and it just continues? Because I gotta think that you guys are in the minority of groups, especially in Southern California, where it's a big private practice group.
It is very hard to fight managed care organizations and employed model. Those can also be almost like golden handcuffs, though. So you get the job and you get the great pension or employment safety, but then I think sometimes the quality goes down in some cases because there's no personal responsibility, and you're not in charge of your brand. You're essentially just a worker bee. I think everybody has to find the practice profile that works for them. So for me, and for all my partners, we thrive off of hard work and creating a brand and brand engagement and brand loyalty. And we thrive off of really innovating to get the very best outcomes. And so that's where private practice has done well for us. Now, it is not easy. I think we work very, very hard. I came from my first gig out of residency was in a managed care organization here in San Diego. And, you know, when people are looking for jobs and they're coming from maybe managed care and looking at private practice, they might say like, "Oh, the grass is always greener." But sometimes the grass is greener on the other side because it's fertilized with BS. So you have to really look into what is actually happening. So always pull back the curtain. I always tell everybody like look under the rug, kick the tires around before you change your practices to see what you're actually getting into. There are definitely pros and cons. So like when I worked at the managed care practice, I was a 9 to 5 worker bee. Yeah, I was a peon, and the culture of the practice was really weird, so it didn't fit with me. But people do that and are able to get a good pension and retire, and it's pretty. You're a 9 to 5 orthopedic surgeon. I work probably twice as hard in my private practice job, but for me, it's been much more fulfilling because I've been able to build it the way I want it, and I can also control for my quality, and I can also control for my partners who they are and do they fit with my culture. And so that's the trade-off, really. And so, but for us, I mean, one thing we do is we're part of a clinically integrated network with 2 of the major university systems down here. So that helps us with insurance reimbursement. It also gives us a pathway for complex referrals for all of our specialists. And so that allows for us to access the university system if we need it for a tough case that maybe is outside of our wheelhouse. So if I see an ortho-onc case, I don't do that as a shoulder elbow guy, but I know I can quickly refer to one of my buddies at UCSD who's an amazing ortho-oncologist, and I can call him and say, "Hey, Frank, I got this for you. We can send it through the CIN directly to you." And then he can give the patient the excellent care that they deserve. So it also creates like a nice conduit back and forth for referrals as well, and know that you have that safety net if you need it. So that's been super helpful. And then I think it's been about building slowly but deliberately. So we've expanded now surgery centers, physical therapy, lab, imaging, and multiple doctors and PAs. But it's expanding our services as we need it, and then making sure that we're covering for things that are in need. So for instance, like I'm expanding my practice and I don't need another shoulder surgeon, but what I do need is an arthroplasty surgeon. And so my focus is on getting someone that does something that's going to elevate what we bring in the practice and not dilute our model.
Also, yeah, I also think that's really important because I know, especially if you guys have this large multidisciplinary group where you can refer within your own network. Um, where I practice, we don't have that. And so I know that you have seen this as well. If I refer somebody to a consultant and it doesn't go well, they blame me. So it's really important that you've got people that you can trust, that you know are going to treat your patients well, that have the same attitude and culture about practicing medicine that you do, so that when your patients come back to you, they're pleased and they trust you because you took good care of them. You sent them to somebody that has the same philosophy that you do. So I think it's terrific that you have that large network that you're able to. And one of the things I was curious about, you kind of touched on this earlier, is you're all in private practice. Obviously you have a business manager, an office manager, and I don't know a lot about California, but my understanding is it's super competitive. And how do you guys go about negotiating contracts? I mean, you have some power behind you with that large of a group. You can negotiate better than a 3-man group. But How has that affected your practice over time that you were able to take this large number and negotiate favorable contracts for you?
Yeah, no, it's been definitely safety in numbers, and then using the clinically integrated network. That then, everyone in the CIN from all over. There are multiple practices in this network, so it's like us plus the universities can then use that to negotiate contracts. So that's been a huge boon. And then also for ones that we have individual contracts that are outside of the CIN, we go to them and be like, hey, look, we give you these number of providers with these outcomes. So we collect our outcomes and then bring them to the insurance companies directly and say, like, this is what we're doing compared to what the population is doing. We really need a better contract. So a really common one has been, like, for instance, length of stay for colon resections. My brother's lengths of stays are like a day or something, and the average is 4 days in the town in here in San Diego. So we can go to the insurance company and be like, hey, look, like, his length of stay is a day versus 4 days. It's 3 less days you're paying in the hospital for this, and his outcomes are excellent, which a much lower complication rate than anybody else in town. We need a better contract, and they're willing to pay for that because their cost savings of the length of stay in the hospital and all that stuff certainly outweighs what they would pay us more for better reimbursement.
Well, okay. I really enjoyed that discussion there. And as we kind of bring this to a close again, how do you guys, we didn't talk about this the other day when in our pre-op call. How do you handle marketing? Do you have to market with being as large as you are and as encompassing as you are, or is it just word of mouth, or do you actively market your practice?
No, we have an amazing marketing team throughout SoCal, and then we all individually do some marketing. So we're very frequently, a lot of us go onto local television and news stuff. I was on recently talking about Lindsey Vonn and her injuries as, like, a local expert on orthopedics, and I do some volunteering for the U.S. Olympic Committees for their sports medicine program. So it was a great segue. Y'all heard James Vanderbeek unfortunately passed away from colon cancer, and then March is Colon Cancer Awareness Week. So my brother has been on TV encouraging people to get their colonoscopies and talking about gut health. We've had our colleagues in cardiology talking about new drug-eluting stents, and so we all kind of get on there, get on the airwaves. Has been a really great way of marketing ourselves, and then and making sure we're going into the community. So we do a lot of talks at the hospitals or in community centers, and that's been very, very helpful.
So that's terrific, and I applaud you all for that. And it sounds like it's a hand in glove fit between you and your partners in the community. So again, we're going to bring this to a close. I can't thank you enough for your time, Schultzel, and I also want to thank Fairwinds Medical for having the wisdom to. This is the third podcast that we've done with as a peer-to-peer podcast. The other ones have been with business people and administrators and things like that, which are fine. But I think that going peer to peer, I learned a lot tonight, and I think that our fellow orthopedic surgeons are interested in that type of dialogue because you don't get that very often anymore. So I appreciate your time. I appreciate your expertise. Enjoy the conference. Be, have fun, and I look forward to seeing you next time at a conference. And again, I thank you, Dr. Mark Schnutzel. Really appreciate your time. Thank you so much.
My pleasure. Thanks for having me.
You bet. Thank you.